Welcome. I'm Jeanette Lubin, PMHNP student, and I'm excited to guide you through this advanced study series on substance use disorders and integrated psychiatric care. In this video, we'll explore evidence-based frameworks, clinical reasoning, and the tools that shape safe, compassionate, and effective practice. Let's begin. In our study guide on substance use disorders, we'll explore Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision criteria, neurobiology, screening, motivational interviewing, American Society of Addiction Medicine, and harm reduction. This guide is tailored for psychiatric mental health nurse practitioner board-level preparation. Addiction alters brain circuitry, particularly the mesolimbic reward pathway. Substances cause large dopamine surges, hijacking this system. Addiction progresses through binge, withdrawal, and craving phases. Withdrawal symptoms vary by substance, with some life-threatening. Neuroimaging reveals addiction is not about willpower. Brain changes and craving are biological, with recovery taking months. Welcome to our session on Psychiatric Mental Health Nurse Practitioner Board-Style Case Studies. We'll explore complex clinical scenarios integrating Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision diagnostic reasoning, American Society of Addiction Medicine assessments, motivational interviewing, harm reduction, and more. Each case includes a vignette, clinical dilemma, and evidence-based rationale. Addiction involves 3 neurobiological phases: binge, withdrawal, and craving. Binge use increases dopamine in the mesolimbic pathway, reinforcing drug-reward links. Withdrawal leads to dopamine depletion and stress, causing anhedonia. Craving arises from weakened prefrontal control and amygdala activation, driving compulsive drug seeking. Brain recovery can take over a year. Treatment matching is crucial for effective care. Mild substance use disorder benefits from outpatient care and motivational interviewing. Moderate to severe substance use disorder requires intensive outpatient program/partial hospitalization program with medication-assisted treatment. Severe opioid use disorder needs residential treatment with methadone or buprenorphine. Severe alcohol use disorder demands medical detoxification. Adolescents benefit from family therapy, while harm reduction suits those not ready for change. Consider the 6 American Society of Addiction Medicine dimensions for comprehensive assessment. Let's review a few case studies. Practice makes perfect. 2. Case: secondary disorder model, psychosis. A 34-year-old man using high-potency methamphetamine presents with paranoia, auditory hallucinations, and formication. No negative symptoms. Question: what is the most likely diagnosis? A. Schizophrenia. B. Bipolar I disorder. C. Stimulant-induced psychotic disorder. D. Schizoaffective disorder. Correct answer: C. Rationale: research states stimulant psychosis presents with overwhelming positive symptoms and absence of negative symptoms, mimicking schizophrenia but caused by neurotoxicity. Case: Shaw notes that THC acts as an environmental trigger for schizophrenia in genetically vulnerable individuals, especially young men. Sequential treatment failure. A clinic requires sobriety before treating depression. Question: according to the document, what is the best critique? A. It prevents medication interactions. B. It improves abstinence. C. It is outdated and produces poor outcomes. D. It is required by DSM-5-TR. Correct answer: C. Rationale: research explicitly states sequential treatment fails patients and must be replaced with integrated care. Cocaine, short half-life. A patient binges crack cocaine every hour. Question: which pharmacologic property drives this pattern? A. High bioavailability. B. Short half-life, 0.7 to 1.5 hours. C. Slow onset. D. Long duration of action. Correct answer: B. Rationale: research states cocaine's short half-life drives frantic binge cycles. Contingency management. System resistance clinic refuses CM. We shouldn't pay people to stay sober. Question: what is the best evidence-based response? A. It is unethical. B. It is ineffective. C. It is the strongest evidence-based treatment for stimulant abstinence. D. It is too expensive. Correct answer, C. Rationale. Research cites Cochrane Review plus Cicerone and Choctaw. CM is most effective, but stigma blocks implementation. Cocaine use disorder. Pharmacotherapy. A patient wants medication for cocaine use. Question: which option has emerging evidence? A. SSR is B. Topiramate. C. Benzodiazepines. D. Gabapentin. Correct. Answer: B. Rationale. Topiramate and stimulant replacement strategies as promising. Methamphetamine use disorder. ADAPT-2 trial. A patient wants evidence-based medication. Question: which combination showed benefit? A. Methadone plus naltrexone. B. Buprenorphine plus SSRIC. Extended release naltrexone plus high-dose bupropion. D. Disulfiram plus gabapentin. Correct answer, C. Rationale. Your PDF cites ADAPT-2 trial showing significant reduction in meth use. Cannabis withdrawal. Diagnostic confusion. Daily cannabis user reports insomnia and anxiety after stopping. Question: why is diagnosis challenging? A. Symptoms mimic bipolar disorder. B. Withdrawal mimics GAD and insomnia disorders. C. Cannabis withdrawal is rare. D. Symptoms indicate schizophrenia. Correct answer, B. Rationale. Your PDF states cannabis withdrawal causes rebound anxiety and insomnia. Cannabis and depression. Treatment failure. Depressed patient uses cannabis nightly to sleep. Question: what is the best explanation? A. Cannabis treats depression. B. Cannabis improves REM sleep. C. Cannabis worsens depressive symptoms and SSRI outcomes. D. Cannabis has no psychiatric effects. Correct answer, C. Rationale. A 2024 systematic review showing cannabis worsens MDD prognosis. Cannabis and bipolar disorder. Risk bipolar. One patient uses high-potency THC daily. Question: what is the most likely consequence? A. Reduced mania. B. Improved sleep. C. Earlier onset plus worsened mania plus rapid cycling. D. No effect. Correct answer, C. Rationales. Cannabis is gasoline on a fire for bipolar disorder. Cannabis-induced psychosis versus schizophrenia. 19-year-old heavy THC user has hallucinations for 3 days. Question: what is the best next step? A. Diagnose schizophrenia. B. Detox plus longitudinal observation. C. Start clozapine. D. Begin mood stabilizer. Correct answer, B. Rationale. Your PDF emphasizes detox plus time to differentiate THC psychosis from schizophrenia. CHS. Pathognomonic sign. Chronic cannabis user with vomiting relieved only by hot showers. Question: what is the diagnosis? A. Gastritis. B. Cyclic vomiting syndrome. C. Cannabinoid hyperemesis syndrome. D. IBS. Correct answer, C. Rationale. Compulsive hot water. Bathing is pathognomonic. CHS treatment. Ineffective medications. Ondansetron fails to relieve vomiting. Question: what is the best next step? A. Increase ondansetron. B. Topical capsaicin or haloperidol. C. Start SSRID. Give IV fluids only. Correct answer, B. Rationale. Standard antiemetics fail. Capsaicin and antipsychotics work. Medical marijuana. THC versus CB. D. Patient wants cannabis for anxiety. Question: which formulation is safest? A. High THC concentrate. B. CBD dominant oil. C. THC edibles. D. Smoked cannabis. Correct answer, B. Rationale. CBD is anxiolytic and mitigates THC-induced paranoia. CBM for insomnia. Evidence patient wants CBM for insomnia. Question: which evidence supports this? A. THC suppresses REMB. Balanced THC to CBD increases melatonin and improves sleep quality. C. Cannabis has no sleep effects. D. CBD causes sedation. Correct answer, B. Rationale. Ride et al. 2023. found balanced THC to CBD oils increased melatonin and improved insomnia scores. CBM for chronic pain. Root preference patient wants smoked cannabis for neuropathic pain. Question: what is the best recommendation? A. Smoking is preferred. B. Oral CBM oils provide stable analgesia and avoid lung harm. C. Edibles are safest. D. Vaping is recommended. Correct answer: B. Rationale. Oral oils provide steady relief and avoid combustion risks. CBM as opioid-sparing strategy patient on 60 mmE wants to reduce opioids. Question: which CBM benefit is most relevant? A. THC treats opioid withdrawal. B. CBM reduces opioid dose without respiratory depression. C. CBM replaces opioids entirely. D. CBM prevents overdose. Correct answer: B. Rationale. CBM is recommended for greater than 50 mmE to reduce opioid burden. Methamphetamine, protracted withdrawal, week 2 of abstinence, persistent anhedonia. Question: what explains this? A. Serotonin depletion. B. Long-term dopamine receptor damage. C. GABA rebound. D. THC withdrawal. Correct answer: B. Rationale. Northrop and Yamamoto, 2015. Describe dopaminergic neurotoxicity causing persistent anhedonia. Protracted withdrawal due to dopamine receptor burnout. Cocaine daily behaviors. Short half-life patient uses crack every 45 minutes. Question: which behavior pattern does the short half-life drive? A. Morning-only use. B. Frantic compulsive binge cycle. C. Slow escalation. D. Weekend-only use. Correct answer: B. Rationale. Cocaine's short half-life drives compulsive binges. Cannabis and psychosis. Genetic vulnerability. Patient with COMT variant uses high-potency THC. Question: what is the most likely outcome? A. No psychiatric risk. B. Reduced anxiety. C. Increased risk of psychosis. D. Improved cognition. Correct answer: C. Rationale. COMT and AK. T1 variants multiply THC-related psychosis risk. Integrated Care Leadership. PMHNP wants to improve dual diagnosis outcomes. Question: what is the most effective action? A. Refer psychiatric cases elsewhere. B. Treat addiction only. C. Champion integrated psychiatric plus SUD care within the clinic. D. Avoid trauma work. Correct answer: C. Rationale. PMHNPs are uniquely positioned to lead integrated care models. Champion integrated psychiatric plus SUD care. ASAM multidimensional placement, complex case. A 42-year-old woman with severe alcohol use disorder presents 24 hours after her last drink. She is tremulous, BP 164/98, HR 118, CIWAAR 21. She has cirrhosis, thrombocytopenia, and lives alone. She reports passive suicidal ideation but denies intent. She is motivated for treatment. Question: based on ASAM criteria, what is the most appropriate level of care? A. Level 2.1 intensive outpatient program. B. Level 3.5 clinically managed residential. C. Level 4.0 medically managed inpatient withdrawal management. D. Level 1 outpatient services. Correct answer: C. Rationale. CIWAAR 20 plus autonomic instability plus cirrhosis equals high biomedical risk, leads to requires 24-hour medical monitoring. Passive SI increases Dimension 3 severity. Living alone worsens Dimension 6. Level 3.5 B is insufficient for seizure/DT risk. Level 2.1 A and Level 1 D are unsafe. Evoking change and ambivalence. Case: a 33-year-old man with opioid use disorder says, "I know fentanyl is dangerous, but it's the only thing that keeps me from feeling sick. I'm not ready to stop." Question: which MI response best evokes change talk? A. You need to stop using fentanyl immediately. B. Let's talk about treatment options. C. Part of you relies on fentanyl to avoid withdrawal, and part of you is worried about the danger. D. Withdrawal is uncomfortable, but you can get through it. Correct answer, C. Rationale. This is a double-sided reflection, the most evidence-based MI strategy for ambivalence. A is confrontational, leads to increases resistance. B jumps ahead prematurely. D minimizes the patient's experience, leads to breaks, MI spirit. Neurobiology, linking symptoms to brain changes. Case. A patient with stimulant use disorder reports profound anhedonia, hypersomnia, and depression 48 hours after stopping methamphetamine. Question. Which neurobiological change best explains these symptoms? A. Upregulation of GABA receptors. B. Dopamine depletion in the mesolimbic pathway. C. Increased glutamate activity in the hippocampus. D. Upregulation of mu-opioid receptors. Correct answer, B. Rationale. Methamphetamine causes massive dopamine release, followed by dopamine depletion, producing anhedonia and depression. GABA changes, A, relate to alcohol/benzos. Glutamate, C, relates to alcohol withdrawal, excitotoxicity. Mu-opioid receptors, D, relate to opioid tolerance/withdrawal. Trauma versus SUD versus mood disorder case. A 29-year-old woman uses cannabis daily. She reports nightmares, hypervigilance, irritability, and emotional numbing. She says cannabis keeps me calm. No withdrawal symptoms. Question. Which diagnosis must be ruled out first before diagnosing cannabis use disorder? A. Bipolar disorder. B. ADHD. C. PTSD. Generalized anxiety disorder. Correct answer, C. Rationale. Her symptoms, nightmares, hypervigilance, numbing, are classic PTSD, and cannabis may be used as maladaptive coping. DSM-5-TR requires ruling out trauma-related disorders before diagnosing SUD. Bipolar A and GAD-D do not explain nightmares/hypervigilance. ADHD-B does not explain trauma symptoms. Harm reduction. Prioritizing immediate safety case. A 25-year-old man injects heroin and reports 2 overdoses reversed with naloxone. He shares needles with friends and is not ready for abstinence. Question. What is the most urgent harm reduction intervention? A. Initiate buprenorphine. B. Refer to residential treatment. C. Provide naloxone and syringe services program referral. D. Encourage abstinence. Correct answer, C. Rationale. Overdose plus needle sharing equals highest mortality and infectious disease risk. Naloxone plus SSP equals evidence-based, immediate risk reduction. Buprenorphine, A, is helpful but not the most urgent. Residential, B, requires readiness. Abstinence encouragement, D, is not harm reduction. Screening tools. Choosing the correct tool case. A 16-year-old presents with declining grades, irritability, and reports vaping THC to chill. His mother is concerned. Question. Which screening tool is most appropriate? A. AUDIT. B. DAST-10C CAGE. D. CRAFFT. Correct. Answer, D. Rationale. CRAFFT is validated for ages 12 to 21. AUDIT and CAGE are adult alcohol screens. DAST-10 is adult drug screening. Co-occurring disorders. Timeline clarification case. A 40-year-old man with severe alcohol use disorder reports depressed mood, insomnia, and anhedonia for the past 3 weeks. Symptoms began after losing his job due to drinking. Question. What is the most accurate interpretation? A. Major depressive disorder. B. Bipolar II disorder. C. Alcohol-induced depressive disorder. D. Adjustment disorder. Correct answer, C. Rationale. Symptoms began after escalation of alcohol use leads to substance-induced. MDDA requires symptoms independent of substance effects. Bipolar II, B, requires hypomania. Adjustment disorder, D, does not explain anhedonia, MOUD. Choosing the right medication case. A 34-year-old man with opioid use disorder wants medication treatment. He has been abstinent for 10 days in jail and is highly motivated. He refuses agonist therapy. Question: which medication is most appropriate? A. Methadone. B. Buprenorphine. C. Extended release naltrexone. D. Clonidine. Correct answer: C. Rationale. Naltrexone requires 7 to 10 days abstinence, which he meets. He refuses agonists leads to methadone, A, and buprenorphine, B, are inappropriate. Clonidine, D, treats withdrawal, not long-term. OUD, complex case, integrative PMHNP decision-making. Case: a 55-year-old man with severe alcohol use disorder, hypertension, and diabetes presents for follow-up. He has been abstinent for 2 months, but reports intense craving when stressed. He attends outpatient therapy weekly. BP is stable. He denies withdrawal symptoms. Question: which integrative approach best supports relapse prevention? A. Increase therapy frequency only. B. Add medication for AUD plus continue therapy plus address stress triggers. C. Refer to residential treatment. D. Encourage meditation and exercise only. Correct answer: B. Rationale. Evidence-based relapse prevention equals multimodal care. OMAT, naltrexone or acamprosate, O psychotherapy, O stress management interventions. Residential, C, is not indicated. He is stable and abstinent. Meditation/exercise, D, are helpful but insufficient alone. Therapy alone, A, misses biological craving mechanisms. Withdrawal syndromes vary by substance. Alcohol and benzodiazepine withdrawal can be life-threatening due to excitotoxicity, causing tremors, hypertension, seizures, and delirium tremens. Opioid withdrawal is extremely uncomfortable but rarely fatal, with symptoms like myalgias, diarrhea, and piloerection. Stimulant withdrawal causes hypersomnia, depression, and severe dysphoria, with high suicide risk. Clinically, addiction is not a matter of willpower. Neuroimaging shows changes in prefrontal volume and dopamine signaling. Craving is biological. Relapse rates are similar to other chronic diseases, and brain healing may take 12 to 18 months or longer. Conditioned cues can trigger craving through amygdala activation. Universal screening uses validated tools across all settings. SBIRT includes screening, brief intervention, and referral to treatment. The AUDIT assesses alcohol use risk, with scores guiding interventions from education to referral. The AUDIT-C is a rapid screen. The DAST-10 assesses drug use severity. The CAGE screens for alcohol dependence. The CRAFFT screens adolescents for substance use risks. Assessment goes beyond screening and includes use patterns, treatment history, psychosocial factors, consequences, co-occurring disorders, and readiness for change. Motivational interviewing is a collaborative, person-centered counseling style that recognizes ambivalence as normal. Its spirit includes partnership, acceptance, compassion, and evocation. Core skills include open questions, affirmations, reflections, and summaries. Change talk includes desire, ability, reasons, need, commitment, activation, and taking steps. Sustained talk is addressed through reflection, double-sided reflection, shifting focus, and rolling with resistance. MI aligns with the stages of change: pre-contemplation, contemplation, preparation, action, maintenance, and relapse. The ASAM criteria guide placement into levels of care using 6 dimensions: intoxication and withdrawal, biomedical conditions, behavioral health, readiness to change, relapse risk, and recovery environment. Levels of care range from early intervention to outpatient, intensive outpatient, partial hospitalization, residential, and medically managed inpatient services. A placement example involves a patient with severe alcohol use disorder, CIWAAR score of 18, cirrhosis, hypertension, diabetes, and limited support. This patient requires level 4.0 medically managed inpatient care, followed by level 3 residential treatment. Harm reduction is non-judgmental, prioritizes safety and well-being, centers lived experience, addresses inequities, and provides honest risk information. It recognizes a continuum from active use to safer use, reduced use, and abstinence. Strategies include syringe services, fentanyl test strips, naloxone distribution, housing first, low-threshold care, and safer use education. Medication for opioid use disorder reduces cravings, withdrawal, and mortality. Methadone is a full agonist, buprenorphine is a partial agonist with a ceiling effect, and naltrexone is an antagonist requiring abstinence before initiation. Stigma-reducing language replaces terms like clean or addict with person first, clinically accurate language such as in recovery or person with a substance use disorder. As you continue your journey toward advanced psychiatric practice, remember that mastery comes from integrating science, compassion, and clinical judgment. Substance use disorders are not moral failings. They are complex biopsychosocial conditions shaped by neurobiology, environment, trauma, and resilience. Every patient you meet will bring a unique story, and your role as a PMHNP is to listen deeply, assess holistically, and respond with evidence-based care grounded in dignity and respect. Whether you're applying DSM-5 TR diagnostic reasoning, navigating ASAM levels of care, practicing motivational interviewing, or delivering harm reduction interventions, you are shaping safer, more equitable systems of care. Keep studying, keep questioning, and keep showing up with curiosity and courage. The work you do matters, and the impact you make will ripple far beyond the clinical encounter. Thank you for learning with me. Stay committed, stay inspired, and stay grounded in the mission of healing. The following references reflect the evidence base that informed this PMHNP study guide. Core diagnostic frameworks include the DSM-5 TR from the American Psychiatric Association and the ASAM criteria for level of care determination. Motivational interviewing principles are drawn from Miller and Rollnick's foundational text, and screening tools such as the AUDIT, DAST-10, CAGE, and CRAFFT come from their original validated sources. Neurobiological concepts are supported by research from the National Institute on Drug Abuse, as well as studies describing methamphetamine-related dopaminergic neurotoxicity. Evidence for stimulant treatment, including contingency management and the ADAPT-2 trial, is based on recent Cochrane reviews and clinical research. Cannabis-related findings, including psychosis risk, withdrawal syndromes, cannabinoid hyperemesis, and CBD-dominant formulations, are grounded in emerging literature from 2022 through 2025. Trauma-informed and integrated care models, including COPE, are supported by contemporary work in co-occurring disorders and SAMHSA guidelines. Together, these sources provide the scientific foundation for the clinical reasoning, case studies, and treatment frameworks presented in this guide. Thank you for learning with us. Your dedication to evidence-based, compassionate psychiatric care truly makes a difference. As you move forward in your practice, remember to see each patient as a whole person, someone deserving of dignity, empathy, and human connection. Treatment is never just an algorithm or a checklist. It's a relationship grounded in compassion. Jeanette Lubin, PMHNP-student,